Martin struggled with the title of this talk. It actually should really just be called a brief summary of things getting in the way of what seems like a really good idea. So one of the best things I find about when I talk to people about making health research openly available is that it's really not a hard sell. It's almost universally agreed that publicly funded health research should be publicly accessible. So building up a strong culture of health research, it generates a cycle of positive outcomes, both for the individual health setting, for the staff there, for the patients, and for the service users. But also in the longer term, it contributes to population health literacy, it increases accountability, and it increases trust in healthcare providers. So the benefits very much far outweigh any associated costs. But unfortunately, the practical realities of transitioning to fully open models are quite complex. And health research activity is a little bit like the health system itself. It can be unequal and uneven. So I have to do the obligatory, we're launching a new strategy today and I'm not at it, so I have to do the obligatory, this is about the library bit. So the HSE library, it's an integrated national library service delivered through 28 separate sites around the country, which are mostly based in acute hospital settings, and through our national eHealth digital library. So since 2018, we've transitioned from a regional structure, so fragmentary structure, into a centralised national service with equity of access at the core of our mission. And we provide resource access across all of the HSE and the voluntary health sector. And we also provide access to BMJ best practice to everyone in Ireland on the national IP. So with such a huge user base, obviously our spend on electronic resources is very substantial. If you have a figure in your head, whatever that figure is, double it and then probably double it again. It's very substantial. Despite all that though, we don't have transformative agreements in place to translate some of those subscription fees that we pay into article processing charges for publication. So just a little bit about the HSE Library's tradition with supporting open access. So LENIS, the Irish Health Research Repository, was launched way back in 2009 as a way to house all the research output, not just of the HSE, but of Irish health researchers, even those not based in Ireland, and to provide a route for green open access. That was followed then by the Open Access Awards, which were established in 2014 as a way to encourage and to reward open access practices across all the health disciplines. In 2018, a new research and development function was set up within the HSE. So up until that point, there had been no central department, no oversight at all of research across the HSE. So one of their first tasks in establishing this function was to get a baseline of the research activity across the HSE and all of its funded activities to figure out what research was actually happening. So then we get to 2022 and the National Action Plan for Open Research is launched, and that really kind of sets a fire under everything. It sets a very ambitious target of achieving 100% open access to research publications by 2030. So with all that new momentum around open research, we started looking at how the next phase of open research support in the HSE Library would evolve. So that 2019 benchmarking survey of research activity across the HSE and its funded organisations gave us confirmation of what we kind of knew already anecdotally. So it also illustrated the complexity of the health research practitioner research ecosystem. 60% of research active respondents are not academically affiliated, so they're not based in an academic institution, they have no association with an academic institution. In terms of where in the health service research is happening, 40% of it is happening in the acute hospitals, 27% of it in community care settings, and only 4% is coming from general practitioners. So there's also no formal publication policy within the HSE. So determining accurate figures for research output across the health service is very challenging, especially with traditional metrics. Much of the research activity is not actually published in peer-reviewed publications, but it ends up in grey literature or in guidelines. And the publications that do get produced are often not affiliated directly to the HSE, but to the individual hospital or the hospital department. And for research active staff who have a dual affiliation with an academic institution, their publications are usually affiliated to the academic institution. So effectively, the true volume of output is completely obscured and impossible to quantify. There's also a lot of regional disparities with the bulk of any of the Scopus indexed publications coming out of the acute Dublin hospitals. So what we were able to confirm with that baseline study is that the majority of research active staff in health and social care services are operating outside of an academic affiliation. This completely excludes them from the transformative, and I agree with Dave, they are not transformative, the transformative publisher agreements that are the basis for open academic publishing, and it leaves them liable for article processing charges. That really puts a significant barrier to achieving that 100% open access for this cohort. And it's a demonstration of the inequalities in the current open publication routes. So to address this, or to answer the question that Dave said of what do you do, what can you do to address this, I got together with Dr. Gemma Moore of the HSE's Quality and Patient Safety Directorate last summer, and we put a project submission into the National Open Research Forum's Open Research Stimulus Fund, which we were really happy to be accepted for, so we got our funding. Our motivation essentially was to develop an alternate pathway for health and social care practitioners who aren't academically aligned to publish and to make their work openly accessible without any financial burdens to them. We also wanted to build on and to formalise some of the existing communities of practice who champion open health research in the health service. The project brings together a group of partners with a mix of experience and expertise in the health sector and in open publishing. So the group includes representatives from the Irish College of General Practitioners, the Irish Open Access Publishers, Marie and Jane, the RCSI Library, and UCD School of Nursing, Midwifery and Health Systems. We're especially happy to have ICGP on board because we particularly targeted supporting research from general practitioners. Okay, so what's the plan? Right, the plan is, first of all, to establish a formal open health research network, drawing on the existing members of the Lennis Repository Working Group and the communities of open research champions in the HSE. A key enabler to this is to recruit an open health research engagement officer who will bring together this coalition to promote and educate on open research publication and build the network. Second part then is Yay Diamond Open Access Publishing will establish a multidisciplinary Diamond Open Access journal for health and social care research. The hiring of the Open Health Research Engagement Officer is really pivotal to getting this project moving forward. So that all sounds fantastic, doesn't it? What could possibly go wrong? Big needle scratch here, dun dun dun. If you work in the HSE, somebody I spoke to recently made the very astute observation that the HSE is very good at getting in its own way. Absolutely no lies detected in that statement. Recruitment in the HSE is a lengthy process at the best of times. So we had identified that as a key risk factor in the project plan. We'd put in the approval to hire documentation in September, and it was approved then. Unfortunately, as you'll probably be aware, a recruitment embargo on administrative and managerial grades was extended indefinitely to all grades in November. So the directive from our HR is that during the embargo, all new role requests require derogation directly from the CEO. So it has to go all the way up to the CEO. We applied for the derogation on the basis that, hey, it's externally funded. We got this nice pot of money. You don't need to spend anything on it. But it was rejected on the grounds that it still brings our head count up. It's all about head count. Keep the head count down. Can't hire. So we decided to petition the decision with the support of the national HR lead in the HSE. Meanwhile, the clock is ticking on the funding and on our year-long project. So if you do work in the HSE, you get very clever about how you have to have the plan A, plan B, plan C, plan D, all the way down the alphabet. So we identified that the recruitment was going to be the biggest potential risk. So to address this, we put a contingency plan in place with a list of options for hiring. Options 1 and options 2 were to investigate hiring through 2 of the project partners, ICGP and UCD. So we put proposals through to their HSE, Unfortunately, both of those were rejected. So meanwhile, we went back to North and petitioned to put a stop on the clock of the project. And then in the meantime, we've since gotten the results of our appeal to HR come forward, and we've been allowed to proceed with the post as an expression of interest. So there are some kind of qualifications around that, but the post is now finally advertised and open to anyone currently working in the HSE or any of the voluntary health services. So Dave quoted Cory Doctorow. I'm stealing the quote from the conference website I quite like, which is that universal access to human knowledge is in our grasp, and that's not a bad thing. But my experience is that even with universal agreement, there are going to be significant barriers in the way to getting us there. Whenever those barriers come up, I think it's important to look at what the end goal is. And for us, our target audience for the project, they don't just operate outside of an academic environment, they actually operate outside of the traditional definition of what exactly a researcher is. They are operating without protected time on top of their existing workloads. So 60% of research active staff in the health services conduct their research exclusively outside of their work hours. And the research that they do is usually in response to immediate patient care concerns and challenges, and it's usually conducted, or often conducted, with vulnerable or very underrepresented populations. So just to summarise and say what we're hoping now that we're kind of relaunching the project and putting it back on track is that if we can get through the teething problems, the long-term impacts for health practitioners and the public are what we need to focus on. What we want to do is deliver a route for open publication and fulfil on the ethical commitment that medical research conducted on the public should be accessible by them. So fingers crossed, that's what we'll be able to do.